Assalamu alaikum. Good evening, everybody. First of all, I would like to thank Professor Abdullah Shahab, Professor Joseph Romano for inviting me for this scientific excellent gathering. And actually, I am always share with them, and it's my great pleasure to be always one of the faculty in this meeting. I will try to be as short as I can. We have what we call worsening heart failure implication, worsening heart failure implication for management. What's meant by worsening heart failure event? Worsening heart failure events means that characteristic by development of progressive escalating signs and symptoms of heart failure require intensification of therapy. As we can see, from 1 in 6 patients develop worsening chronic heart failure within 18 months of initial diagnosis. If we look to the paradigm heart failure, we can find that the risk of cardiovascular death or heart failure hospitalization was 46% higher in patients with recent hospitalization versus those with no prior hospitalization. So what's meant by worsening heart failure? We have 3 important things: definition, pathophysiology, and site of care. The definition is worsening of symptoms of heart failure, requiring intensification of treatment, generally include diuretic therapy, occurring in patients with pre-existing heart failure. What is the pathophysiology? This is the disease progression and the congestion. What is the site of care? There is either hospital or emergency department, and recently the definition has been changed because now we have worsening heart failures that can be on outpatient with IV therapy or with escalating of oral therapy. So this is in short about the worsening heart failure definition, pathophysiology, and site of care. And there are 4 domains of patient experiencing a worsening heart failure. First of all, clinical, worsening sign and symptom, severity of the congestion, decreased exercise capacity, event, hospitalization, emergency department visit, outpatient, IV therapy, or oral therapy escalation. Subclinical, we can find the biomarker, imaging device, pulmonary artery pressure monitoring. The outcome, increase the risk of subsequent mortality and rehospitalization, poor health status and the quality of life, need for heart transplant or VAD. This is how can you make an assessment and the target of the congestion during the pre-discharge rate. This patient hospitalized for acute heart failure, you can have clinical assessment, very important, we have what we call congestion score. Optimal, it is 0, acceptable 1 to 2. Then we have weight loss, we have NIHA class, optimal, that patient transferred to NIHA class less than 2. Then we have laboratory, patient with natriuretic peptide, optimal, more than 30% natriuretic peptide decrease. Then the imaging, chest X-ray, left ventricular pressure by echo, IVC, and Lewis. So this is how can you make a rapid assessment and target of the congestion during the pre-discharge phase. As you know, you have already heard about the guideline for heart failure and the update in 2023, and now we are the recommendations that you have. In absence of contraindication, patient with heart failure should be treated with the combination of therapy rapidly. But there is an important point. There is a residual risk in heart failure reduced ejection fraction despite the quadruple therapy. As we can see from EMBER reduced trial and DABA heart failure trials, there is still high incidence of primary cardiovascular outcome, cardiovascular death, heart failure hospitalization, and all cause this. So the second question is that you have to ask about what are the novel way for targeting and monitoring of worsening heart failure. What can we do? First of all, take the opportunity to optimizing the guideline-derived medication. This can be seen in the optimized heart failure trial or in Pioneer trial. We see that the introduction or switch to ARNI reduce the natriuretic peptide and the clinical event. Then trial in patient with worsening heart failure, trial for sotagliflozin, SOLICIT trial, EMBERS trial, Victoria trial, and the Galactica heart failure trial. Of course, I'm gonna highlight just rapidly these studies. We have the combination of loop diuretics plus the furosemide in the form of acetorazumab. If we look 500 milligram IV plus Lasix IV over 3 days in acute decompensated heart failure with congestion, we can see that there is successful decompensation within 3 days after randomization in favor of acetolamide, the combination, and we have successful decongestion at discharge. So the combination is benefit also when we give it. And that's why we can see the diuretic therapy for acute heart failure. It is class 1A, use the intravenous loop diuretics, and the class 2A, where you can combination of loop diuretics with Sazad diuretics, it should be considered in patients with resistant edema who don't respond to increased loop diuretic. A satisfactory diuretic response can be defined as urinary sodium more than 50 to 70 after 2 hours and or urinary volume of more than 100 to 150 during the first 6 hours. The IMBARS trial benefit with empagliflozin 10 milligram in patient with acute decompensated heart failure, we can find that in the primary endpoint, the time of all-cause death of first heart failure, there is 36 more likely to experience a clinical benefit compared with patient in placebo. Also, in the Vrisiguat trial, we can find that there is improvement or there is significant improvement by using the Vrisiguat, and we can see the guideline 30 class 2B. Vrisiguat may be considered in patients with NIHA class 2 to 4 who have had worsening heart failure despite the treatment with ACE or ARNI. This is slide summarized all the randomized clinical trial in different hospitalization phases, either acute heart failure, pre-discharge, post-discharge. Of course, we will not lose too much time. But very important thing now, the rationale for simultaneous or rapid sequence initiation and duration of guideline-derived medication for worsening heart failure. This is very important. This comes recently from the strong heart failure trial, and as all of you know, that the guideline updated because of this trial. As we can see, high intensity rapid sequence stimulation arm guideline draft optimized medication in comparison to usual care associated with significant lower risk of death or heart failure hospitalization, improved patient reported death status NIHA class, improvement clinical congestion and incremental lowering of NT pro and B, substantial higher use dosing of guideline draft medication throughout follow-up, no excess risk of serious adverse event. So what we have, if we make delay or omitting guideline directed heart failure medication, then we'll have more hazardous patient never being titrated as guideline derived medication or substantial delay, worse quality of life and health status, excessive risk of disease progression, and preventable death and hospitalization. So, in a stronger trial, does the rapid escalation has impact on left ventricular ejection fraction? No impact for left ventricular ejection fraction, in high intensity arm or the usual care arm. This is the whole medication for worsening heart failure. I like this one. If you look this, the indication for each medication, beta blocker can be indicated where clinically evolumic hemodynamic state, but it should be used in cautious ways, approaching evolemia with good blood pressure, rapid effect believed to be considered for acute dialytic heart failure episode, stop where there is significant volume overload or perfusion, MRA where patient with glomerular filtration rate more than 30, potassium less than 5, and stop potassium sometimes needed, used in cautious for patient with history of hyperkalemia, declining renal function, stop in acute kidney injury or glomerular filtration rate less than 30. ARNI, glomerular filtration rate as we know more than 30, potassium less than 5, and the systolic blood pressure should be more than 100. Used in cautious when systolic blood pressure was 95 to 100, and stop when the systolic blood pressure less than 90. SGLT2 inhibitor, it's the ministry now of the medication. It can be used clinically in evolemic, no congestion of fluctuation of renal function, glomerular filtration rate more than 20. Use be cautious in declining renal function. Stop when the renal function less than 20. Vrisiguat, we know already evidence of worsening heart failure, NIHA class 2 to 3 or 4, ejection fraction less than 45%. The cautious were in patients systolic blood pressure more than 100 or IV measure more than 24 hours, stop when systolic blood pressure less than 100. So this is in rapid, how can you use each drug and the cautious and stop it. So what is the device technology for remote heart failure monitoring? This is very important. Now we can monitor the pulmonary artery pressure that can give us an idea before the heart failure event. This is what we call increased pulmonary artery pressure before heart failure event. This is the recent trend now, the device technology, remote heart failure monitoring, and this we can find a model for optimal implementation of digital health innovation. Of course, short of time, we cannot talk about this. Then, the third important question, when and how to consider advanced and palliative therapy for patients with worsening heart failure. This is very important. Advanced heart failure therapy, as we know from the guideline, selected advanced heart failure therapy, either heart transplant or mechanical circulatory support as a bridge or longer-term mechanical circulatory support. So this is the advanced heart failure therapy. But this is very important. Why? And how can we deal with the advanced heart failure therapy and the steps? First of all, you have to identify the patient. This is very important, and you have to look for the definition, as we mentioned, of advanced heart failure. Then, referral to advanced heart failure center, assessment for the indication, contraindication, multidisciplinary care, and decision listening to heart transplant or LVAD or palliative care. What are the golden window for referral or consideration of advanced heart failure? This is very important. I like this slide. Why? Because this is very important. NIHA class 3 or 4 symptom, down titration or of an ability to tolerate the guideline-derived medication, frequent hospitalization, frequent arrhythmia or ICD shock, and worsening renal function. This is the golden window, and is that at that time you should think to refer the patient for the advanced heart failure therapy. When to refer? Clinically. Always remember, transition, I need help. This is very important. I, inotropes, NIHA or natriuretic peptide, E, in the organ dysfunction, liver or kidney, E, ejection fraction less than 20, defibrillation, shock, hospitalization for more than one last year, edema and diuresis, low blood pressure less than 90/100, and the prognostic medication. So the referral, evaluation, and some device. All ambulatory patients with advanced heart failure should be considered for referral to advanced heart failure center, unless severe irreversible comorbidity or immediately ferality is present. Comorbidities such as renal insufficiency, liver dysfunction, cachexia, right ventricular dysfunction shouldn't be preclude the referral because they are not infrequently and many of them are reversible. Nevertheless, treatment option and long-term survival rate are still the best if the patient is referred prior to onset. This is the model for advanced heart failure care center, and this is the multidisciplinary care. This is very important to deal or to treat the patient or to refer the patient or advanced heart failure to this center. Of course, this needs another subject. Then we have to know the recommendation for the treatment patient with advanced heart failure. Patient being considered for long-term mechanical support, class 1C, device handling and psychological support. Heart transplantation is recommended in class 1C for patient with advanced heart failure refractory to media or device therapy. Long-term mechanical support can be a class 2A, advice for patient not eligible for heart transplantation. Long-term mechanical support should be considered a patient with advanced heart failure with reduced ejection fraction refractory to optimal medical treatment as a bridge to cardiac transplantation. This is class 2AB. And heart transplantation indication, we know advanced heart failure, no other therapeutic option except for LVAD as a bridge. But the contraindication is very important. We can see that patient with pharmacological irreversible pulmonary hypertension, malignancy with poor prognosis, irreversible liver dysfunction or irreversible renal dysfunction. This is that. And the contraindication, you know it, but psychological instability and insufficient social support. Then we can use the inotropic therapy for advanced heart failure, and one of these addresses either to be congestion refractory to diuretic therapy, assist reversibility and organ dysfunction, bridge to heart transplant, hemodynamic optimization for LVAD and palliative care. One of the most important one is levosimendan as a bridge to the heart failure. This is Spanish experience, which is recently published trial. 2023, and we can see there is a benefit when we're using this levosimendan as a bridge to heart transplant. This patient receiving needed to be heart failure hospitalization may be reduced and no difference in mortality. So the decision process about heart transplant and LVAD, this is very important. Who is the patient that you are eligible only for heart transplant? Patient with biventricular or RV failure, intractable VT, restrictive cardiomyopathy, any cardiomyopathy with a small left ventricular in diastolic dimension, patient refusal of LVAD implantation, contraindication to long-term anticoagulation. However, there is patient eligible for LVAD but not heart transplant, but maybe in the future, patient with severe pulmonary hypertension, pulmonary vascular resistance, more than 6 Wood unit, questionable psychological status, marginal compliance, recent less than 5 years malignancy with favorable prognosis, body mass index more than 35. Eligible only for LVAD, age greater than heart transplant program or other contraindication to heart failure. So in conclusion, my dear colleagues, recognize worsening heart failure as an event marking a new phase in the natural history of heart failure. Recognize the additional residual risk in your patient following a recent worsening episode heart failure. Incorporate worsening heart failure management in clinical practice guideline. The prognosis of patient advanced heart failure is poor, but there is an increasing. This is the last one. If you want. Anyway, recognize time referral to advanced heart failure center, clinical triage for referral, assessment the process, confirm the indication and exclude contraindication. So this is the take-home message that I want all of you to know about the worsening heart failure. Thank you so much for your attention.